I'd like to, I'd like to especially welcome those of you who are new to our little intellectual community, since as Dean Lawler has said, it's really a welcoming of you. And so those of you who are new to our master's programs or are new in our doctoral program, I'd like to take this moment to give you an extra special welcome and thanks for coming. Before I begin to talk about modest doubt, which you may have doubt about, I would like to assure you that I lead a completely pious and blameless life. The topic that I've picked today, case of modest doubt, comes from something that Hector tells Troilus in the play Troilus and Cressida. And he says something really beautiful. He says, modest doubt is called the beacon of the wise. And you know, Shakespeare has this amazing way of, I think, capturing complexities in human thought in very, very simple terms. And I think what Hector is trying to communicate to Troilus is this idea that if one has uncertainty, if one is uncertain about something, that is a sentinel, that is an indicator of something. It's something that we ought to recognize. It's something that we ought to embrace. And ultimately, it is something that we ought to resolve. It is not something that we ought to ignore, because through the recognition, through the embracing and through the resolution of modest doubt lies the path to wisdom. And I think this is a especially germane idea for our talk today, because I think modest doubt essentially animates the entire academic enterprise. I suspect that each and every one of you, especially those of you who are new to us, have a modest doubt. I suspect that each and every one of you has a little grain of sand in the oyster of your mind that nags at you. I suspect that each one of you has a population that you have encountered for whom services could be better. Perhaps each one of you has a little puzzle that you would like to fix. Perhaps you have an intellectual quandary that you would like to resolve. And I suspect that modest doubt is what drives you to an institution like ours. And in fact, I would argue that the recognition of modest doubt is the beginning of a graduate education. That is the purpose of a graduate education. And that the resolution of modest doubt, making sure that that doubt goes away, is the purpose of the academic enterprise. So in many ways, I see modest doubt as being the core of what it is that we do and what it is that we are about. And what I'd like to do in this talk is to explore this idea of modest doubt a little bit. And I'd like to first begin by talking about some of the work that I do and give you an example of how one faculty member, namely myself, resolves my own modest doubts and the modest doubts of the people that I work with. But this talk isn't really about me, it's about you. And so I'd like to spend the next of this, the 3/4 of this talk, talking about how you might yourself resolve some of your modest doubts. And again, I'm directing this primarily to those of you who are new to our shores. I'm going to suggest to you that there are 3 possible ways in which you might resolve your modest doubt. First, by embracing transdisciplinarity. Second, by seeking alternative learning experiences that our university provides and our school provides. And 3, by building the sort of intellectual and social networks that are so critical to your future success. So let me begin by talking about an example from Medicaid policy. Now, I, as Dean Lawler introduced me, I'm someone who studies child welfare, children in the child welfare system, who actually are worthwhile studying because they constitute a very significant minority of children in the country. And these children have considerable rates of use of mental health services. And children in the community, about 1 in 5 of them use services, while nearly half of children in contact with child welfare agencies use mental health services. And the thing is that these services they use services that are very, very expensive, especially psychotropic medications. Children in the community, about 4% of them use psychotropic drugs, whereas children in foster care, 10 times as many of them use psychotropic drugs. Psychotropic drugs are the single most expensive mental health service to insure. And the burden of this insurance falls upon Medicaid agencies. And one of the doubts that Medicaid agencies have is how can we do a good job of resourcing services for these children? In fact, this problem is only going to get worse once the Affordable Care Act provisions get enacted, or Obamacare, as some of us affectionately refer to it as. Right now, for example, The populations that we cover are the bars in yellow. Beginning 2014, we will begin covering these groups of individuals under Medicaid. And what that means is that these red charts collectively will add between 60 and 75 million new Medicaid beneficiaries. How are we going to resource care for a very high need, high use population when we have 60 to 75 million new beneficiaries coming into the Medicaid program? How are we really going to do this? Especially since no one is talking about growing the size of the pie by paying more taxes. So this is the doubt that Medicaid policymakers face. It's certainly not a modest doubt. It's an immodest amount of doubt. And this is the task. Resolution of this doubt is what my colleagues and I are engaged in trying to resolve, in identifying and resolving. So the first thing that we thought about when we needed to resolve modest doubt is we needed a way to think about the problem. We needed an approach. We need a conceptual framework. And this is where I think theory is so important. Those of you who are here, we make you take all these theory classes. The purpose of that is really to give you a framework, give you an approach to inquiry. And we looked at several theoretical approaches that might perhaps help us in this, and we finally came up with the idea of risk. In fact, I wrote a paper on risk adjustment. And I actually have a copy of that paper in my briefcase, and I do think that I have about 25 minutes to read to you my paper so that I can explain in great detail and with great erudition exactly what risk is and how that is relevant to the lives of children in child welfare. But I see from the overwhelming response that I'm getting that that's not a good idea. So instead, let me turn to another example. I can tell you about risk through the example of beer. Now, this, it turns out, is the favorite beverage of one of my faculty colleagues, who shall go nameless. In my extensive research on the topic, I can concur that this is indeed a good one. But what I'm most concerned about is IPA, the India Pale Ale. Do any of you know how India Pale Ale came to be called India Pale Ale? Yeah.
It had to make it stronger so it would survive the sea voyage.
Outstanding. Outstanding. So I do hope that the Student Coordinating Council is serving some IPA in memory of this talk. So that's a wonderful piece of trivia. You're absolutely right. So it turns out that trade between Britain and India, there was an enormous, in the 1600s and the 1700s, consisted of large amounts of ale being shipped from Britain to India. And since in those days it would go all the way from England, where it might be winter, all the way down the Horn of South Africa, where it might be summer, go up the Indian Ocean into the Bay of Bengal, into Calcutta in the midst of a tropical winter, that ale would spoil. And so Lloyd's of London, the insurance company, began charging the British East India Company increasing premiums for the ale that was getting spoiled. And so the East India Company figured out that they just couldn't afford to do this anymore. They talked to the king, and the king instructed British brewmasters to come up with a new concoction that would survive the voyage. And so the brewmasters basically increased the amount of hops, they made it more acidic, and they developed India Pale Ale. India Pale Ale is a classic example of risk, because what we are trying to do is we are essentially trying to do what the British brewmasters were trying to do when it comes to children in child welfare. The first thing that we are trying to do is we're trying to identify characteristics of children in the child welfare system who might account for the greatest amount of Medicaid expenditures. This is analogous to figuring out, are there different spoilage rates between Pale Ale and India Pale Ale? The second thing that we are trying to do is we are trying to find out how expensive is it to cover kids with a certain set of characteristics on the Medicaid program. And this is analogous to figuring out what is the difference in premium between, or what is the difference in proportions between the India Pale Ale versus Pale Ale that a ship actually carries. And the third thing that we're interested in doing is we're really interested in finding out how can we best resource care for these kids, which is in a sense analogous to saying how much should we pay if we assume that 100% of that ship had India Pale Ale. So what the British East India Company was doing in the 1600s and 1700s with beer is exactly what we're doing with Medicaid expenditures today in 2011. And that really is the idea in some ways of risk. And so how did we do this? We collected Medicaid data from about 14 different states. We linked it to a national survey. This involved 2.5 years. It involved lots of data security plans and a whole range of things. And at the end of it, we sometimes felt like this. But what we did find is that we actually found that there is a significant difference between kids who have child welfare involvement when it comes to their med expenditures and kids who do not have child welfare involvement. In fact, it turns out that the burden of being involved in child welfare adds about $491 on average to a single Medicaid beneficiary. And that, in a sense, is the jeopardy of being maltreated when it comes to Medicaid expenditures on drugs. This suggests that Medicaid policymakers certainly ought to be figuring out population-based carve-outs. They ought to be looking at kids in child welfare and resourcing care for those kids preferentially while protecting this amount of dollars for their care. The second thing that we found is that there are significant race-ethnic disparities among that underlie this utilization. Use of medication rates among African American kids in the child welfare system, roughly half of that of white kids in the child welfare system. And if we look at this across kids who have demonstrable mental health need, that is, kids who are needy, it turns out that these differences persist, which makes it what we call a disparity. And these disparities are in the order of about $399. So an African American child with the same level of mental health need, adjusting for a range of other characteristics, costs Medicaid agencies about $399 less compared to a very, very similar child who's only different from this African American child in his race ethnicity, specifically white race ethnicity. And this is clearly a worrisome prospect. And so right now, we're providing this sort of information to policymakers so that they can figure out a way to reduce these disparities among these children. And the other thing that we found is that these disparities are apparent primarily in 3 drug classes. So the antidepressants, antipsychotics, stimulants, and another one. So it's really a fairly focused problem. It's not really a pervasive issue. And so one other thing that we're suggesting is that we're working with Medicaid to say, can you do prior authorization or other forms of pharmaceutical care management so that we can better serve these kids by identifying specific patterns of their use across particular drug categories? So this is one example of how my colleagues and I try and resolve our own modest doubt. So you might ask, so how can you reduce your modest doubt? How can I, as an incoming student, recognize, embrace, and resolve my own modest doubt? And the first suggestion that I'm going to offer to you is to embrace transdisciplinarity. If you notice, the work that I've showed you, this brief overview of the work that I've done, is itself inherently transdisciplinary. I originally started my career in a different discipline. I work on children and child welfare, which is near and dear to the heart of social workers. I work on Medicaid policy, which is near and dear to the heart of people who study public finance. I use health services research methods to study it, which is classically a component of public health. So I really enjoy Dean Lawler calls it being an intellectual dilettante. So I really enjoy sort of wandering across these disciplines and trying to learn the best that I can from my colleagues. And this is certainly something that I would absolutely encourage of you also. And why do we need this? We really need it because initially we were fine with unidisciplinarity. Initially, we had individuals who were wedded to a single intellectual tradition who went off and did their own thing and were lone wolf scholars. And that worked out great for about a couple thousand years until it didn't. And sometime in the 1940s, we began exploring multidisciplinarity. Places like RAND, for example, where you had people from multiple disciplines come together to solve complex problems, but those individuals were still rooted in their own intellectual traditions, and they worked sequentially. They didn't really work jointly. Somebody came in, contributed, left, another person came in, contributed, and left. And this move towards interdisciplinarity was developed a couple of decades ago, 3 decades ago, as a recognition of the fact that multidisciplinarity doesn't seem to have worked. And in interdisciplinarity, we have teams of people who come in and they work jointly. They may be from different intellectual disciplines, and they may be wedded to them to various extents and levels, but they do work jointly and they attempt to integrate their intellectual traditions with one another. What we're finding now is that even this interdisciplinarity doesn't seem to be working very well. And I'll give you one example. And the reason for that is, and the example that I'm going to give you is an example that suggests that the reason for that is the tools of our inquiry are becoming increasingly inadequate to investigate really, really complex problems. In summer, a group of students and I spent the time in 3 villages. Spent time in 3 villages trying to examine what happens when we try to deliver potable drinking water to our village residents. And this is a water pump, and this is a village. And we found that it's actually a remarkably difficult enterprise to figure out how to deliver safe drinking water here. Because it turns out that in order to do this, you have to know something about civil engineering. You need to know how overhead water tanks are built. You need to know something about water flow dynamics. You need to know something about the village ecosystem. You need to know something about sociology, because there is open defecation that pollutes water sources. We need to know something about bacteria, about viruses, and about parasites. We need to know something about diarrheal disease that results from not having safe drinking water. And as it turned out, our students discovered that they needed to know something about aquariums. Because it turns out that the best way to filter water suitable for humans is to adapt technologies that filter water suitable for fishes. And that is a very, very low cost and high ingenuity way of assuring safe drinking water. And we have a few of our TPS students in the audience, and this is just one example, and each one of them actually worked on a set of really, really fascinating questions that displayed this fine disregard for intellectual boundaries that I think I particularly cherished and valued during this experience. So this is what transdisciplinarity requires. Transdisciplinarity fundamentally is a process. It's a way of inquiry. It's an approach to inquiry, which requires team members to spend from different fields to work together over extended periods of time. We constructed teams from social workers and public health professionals and put them in teams together. And they lived together and they worked together for 2 entire months. Now, granted, at the end of it, some became homicidal, but the learning that occurred during that process was certainly very, very valuable. The other thing that transdisciplinarity requires is that it requires them not only to integrate, but also transcend their particular disciplinary boundaries. The solutions that each one of our students came up with had nothing to do with social work. They had nothing to do with public health either. But what they were transcendent solutions. They took the best of social work, they took the best of public health, and they tried to develop a solution that is best applicable and germane for the population that we're attempting to investigate. And the primacy of the problem, I think, is one of the best contributions that a transdisciplinary approach gives us. The other thing to think about as we attempt to resolve modest doubt is to seek alternative learning experiences. In fact, I would argue that much of transdisciplinary work can be achieved through the medium of alternative learning experiences. And what do I mean by that? One example of that is the course that we just did, this immersion course in transdisciplinary problem solving. The course was called Implementing Public Health Interventions in Developing Countries. And in this course, we actually took a group of students who worked on 5 different disease challenges. Now, you might ask, why are social workers interested in diarrheal disease or maternal and child health? And that's a legitimate question. But I think the students who signed up for this course realized that it wasn't so much the what that they were interested in, it was the how. that they wanted to learn. It wasn't so much the specifics of what causes oral cancer that drew them to this enterprise. It was the idea of what can they learn in the solution of a problem that applies to oral cancer that they can then take and apply to any other field of inquiry that they are really interested in, whether that be poverty or child maltreatment or whatever it is that they may be interested in. So the how, I think, is what really attracted them in many ways. And of course, we did have an option. We could teach this here, or we could teach it here. And no prizes for guessing what we ultimately decided to do. Now, as part of the process, our students really explored and expanded their skills into diverse disciplines. So here we have a student who's learning how to perform an oral cavity exam. This is classic public health dentistry. Why should an MPH student learn to do an oral cavity exam? Why should a social worker learn to do an oral cavity exam? Because when you're out there in the field, when you're in the boondocks, in a tiny village that is several hours away from the nearest healthcare facility, you really are the only person there. And if someone comes up to you and shows you a lesion in his mouth and says, "What do you think I should do?" you have to know enough to say, you need to get on that bus and take that 3-hour bus ride to go to the hospital right away, because there is no alternative. And if we don't do that, we effectively condemn that person to end-stage disease. And so we were very emphatic that we needed to send our students out with the kinds of skills that are necessary for effective practice in remote rural areas. And so our students learned how to do chest compressions, and we trained them in AEDs and defibrillators. Our students did they did store audits, and I see Alison out there. So this is Alison, and Alison was doing a project on oral health, and so they wound up in these little stores and did store audits. They asked them what toothpastes they sell, what toothbrushes they sell, what tooth powders are being sold, and they really investigated this on the ground. This is a little village called Vepangadu. Our students went into primary schools, and in this particular instance, the team from tobacco control is actually going into these schools and asking these kids, how many of you have purchased tobacco products at the behest of a family member? And as you can see, all of these kids are raising their hands, suggesting that certainly the We Card program is not alive and well in deep rural India, and suggesting that there are probably that we should have serious concerns about tobacco initiation among students here. This is a major challenge that they confronted. And we also had teams from our cardiovascular diseases team, and Nancy is down there, and they went and looked. This is a little playground. This is a field, a village field, and they were interested in looking at a physical activity intervention, and they were trying to see if there is a physical activity intervention that potentially could be done in order to control hypertension. That was the cardiovascular diseases team. And so they did these direct observations, field observations, to see if that works or not. And students from our maternal and child health team went to the Integrated Child Development Services, ICDS facility here, where they attempted to look at what nutritional support programs were extant and how were these kids really being supported when it comes to their nutrition. And I have to give a shout out to Ravi Chokalingam, who's here, who co-constructed this course with me, without whom I certainly wouldn't have been able to do this and preserve my sanity. Our students did face some fairly tough questioning, because Ravi comes from ICTPH, which is our partner organization in co-teaching this course, and folks from ICTPH asked some fairly tough questions. And so our students, I dare say, dreaded their multidisciplinary team meetings. But this was very much a client-focused course, and learning how to deal with stress is as much part of public health practice as is anything else. So I don't want you to take away this notion that we were really stressed out and that we had no fun at all. Actually, we did have fun. We went out and we played table tennis, and here's Ravi and Ipris. I should hasten to add that Sean and I had a friendly match against two people from ICTPH, and the final score, you'll be delighted to know, was Washington University 1, ICTPH 0. And some of these experiences were interesting and novel. So Nancy and Alison are eating betel leaf. So betel leaf mixed with calcium carbonate is how women in rural India get calcium supplementation. And so our students said, "What is that?" And we said, "Let's find out." And they did. And some of these experiences were somewhat scary. Enough said. And, and all of this was happening in the heart of a region that has profound historical value. It was the seat of the Chola Empire about 1,000 years ago. This temple was built in 1010, was consecrated in 1010 AD. And it's a place of great natural and architectural significance. And so Whitney is also here from the TPS group. And as you can see from the folks who have come back, all of them have survived. The TPS India course is just one example of the kinds of diverse and alternative learning experiences that this school offers. We have faculty who teach in St. Louis, in East St. Louis, Missouri, who do national work. We have winter institutes in India, summer institutes in China. We teach in Brazil, Kenya, Haiti, Dominican Republic, Nepal. Luis is here, so I guess I should put Chile over there. We have individuals who teach in Kazakhstan, in Georgia. So I'm sure I've left out the myriad places where our faculty are involved. Madagascar comes to mind. I know Professor Sharadin's team works there. So we really are in many ways a faculty with global reach. And one of the things that you might wish to do is explore how can you seek learning experiences that enable you to learn from the experiences of other countries. Because sometimes we can actually learn a lot by looking at what other people do. And sometimes they really do it better than we do. The third way in which we, I think, can resolve modest doubt is by building intellectual and social networks. And in some sense, recognizing and embracing transdisciplinarity and trying to seek out alternative learning experiences both effectively culminate in building intellectual and social networks. In some ways, this is the goal towards which those two things are designed to go. And when you really think about it, we really do live in a matrix of intellectual traditions. This is the web of science. And this relates disciplines by journal citations. And so you'll see that public health is over here, social work is over here. The point is that all disciplines are really related to one another, that there are no isolates, as the network people call them. There is no dot that isn't related to any other dot. Every single discipline is related to every other discipline in some way, shape, or form. And the only boundaries, I think, that we impose upon our intellectual traditions are the ones that we decide to do. And so in some ways, I think building intellectual networks perhaps should start from home. By which I mean, I think one of the things that those of you who are new, whether you're in the MSW program or in the MPH program, should perhaps do is break that barrier between the MSW program and the MPH program. Perhaps those of you who are in the social work program might wish to take courses in public health, and perhaps those of you who are in the public health program might wish to take courses in social work. And at the end of it, I bet that you will find that public health and social work are actually not really distinct disciplines, that they really are roughly the same thing. And I'd like to illustrate that to you with a closing example. This is this is an extract from my favorite paper. Unfortunately, I did not write it. It was written by Jeffrey Rose, who for many years wrote and taught at the London School of Hygiene and Tropical Medicine. He was a great epidemiologist, superlative teacher. And let's make this easier to see. The curve in yellow, this one, is the distribution of blood pressure among London civil servants, among Whitehall civil servants. And so anything over here is really bad. 120 is where we ought to be. So everyone to the right of this line, that area under the curve, are hypertensive. This interrupted curve in blue is the distribution of blood pressure among tribesmen of the Masai Mara, among Kenyan nomads. And as you can see, they have a much better distribution of blood pressure than do the London civil servants. What we do in medicine is that we take people who are at this end and we try and pull them back in. In other words, we are tail pullers in medicine. This is what we try to accomplish, right? But in social work and in public health, we have a more noble and glorious purpose. We're not really tail pullers. We're interested not in taking hypertensive British civil servants and making them into normotensive British civil servants. We're interested in taking hypertensive British civil servants and making them into tribesmen of the Masai Mara, at least as far as their blood pressure is concerned. In other words, we are curve shifters. Right? What we want to do is not do this, but do this, to essentially pull that entire disease distribution to the left. That is the purpose that social work and public health is really engaged in. And you can certainly substitute your dependent variable for anything. And in some ways, if there is a distinction, it's probably a distinction in the outcome. Public health professionals are primarily interested in health outcomes, while social workers are interested in health as well as other outcomes. But in many ways, both of our disciplines are ultimately about curve shifting. And it's only when we, I think, understand and embrace modest doubt, when we find ways to recognize it, when we find ways to resolve it through transdisciplinarity or by engaging in alternative learning experiences, when we do all of this and we resolve modest doubt, then we can curve shift. And it's only when we can curve shift that we can really impact the lives of the populations that we ultimately wish to serve. And I'd bet each one of you that that is what you really want to do. And if that were not what you wanted to do, I would submit to you that you would not be here in the first place. So I'd like to end by saying, go forth and curve shift. I have